Now today I will discuss about the basic pharmacokinetic principles. This is continuation from previous slide. Now, volume of distribution. This volume into which a drug appears to have been dissolved after administration. Clinical relevance, a large VD will require a larger loading dose to have a given concentration. Now, what do you mean by clearance? Clearance of a drug from the body is expressed in volume per unit time. Pathological conditions such as general disease alter the time and course of the clearance. Elimination half-life. The amount of time that it takes for the concentration of a drug to be reduced by half in the body. 5 terminal half-lives are required for a drug to reach the steady state. Terminal half-lives determine the dosing intervals, usually close to 1 terminal half-life to avoid the accumulation. This is a critical concept which when antagonizing the drug effects. Opioids antagonists may have shorter half-life than the opioids themselves. This means that the opioid effect, which such as respiratory depression, may return after the antagonist is eliminated. What is first-pass effect? The biotransformation and/or excretion of a drug by intestinal and hepatic, including biliary mechanisms, follow the absorption of the drug from the gastrointestinal tract before the drug gains access to the systemic circulation. When dosing the drugs orally, it is important to know the higher doses will be required than when given IV. Now, zero-order kinetics. Mechanism of chemical reaction zero-order kinetics, mechanism of chemical reaction in which the reaction velocity is apparently independent of the concentration of all the reactants. Saturation of enzyme metabolism is possible. At saturation, a small increase in the dose will result in large increase in the plasma concentration. For example, alcohol or phenytoin. First order kinetics, the velocity of a chemical reaction is proportional to the concentration of the reactant. Elimination rate constant. The velocity of a chemical reaction is proportional to the product of the active mass, that is the concentration of the reactants. Elimination rate determines how fast a drug is eliminated from the body and is an important component of terminal half-life. The elimination rate may be significantly altered by induction or inhibition of drug metabolizing enzymes. That is, the induction, lower exposure, less drug effect; inhibition, higher exposure, high risk of drug toxicity. Genetics may play a very important role for specific drugs. There are slow and fast metabolizers. A slow metabolizer may accumulate drug quickly when treated with standard doses and result in toxicity. Fast metabolizers with standard doses and result in toxicity. Fast metabolizers will eliminate the drug quickly and may have less or no drug effect. Accordingly, slow metabolizers will require much smaller doses and fast metabolizers much higher doses than normal metabolizers. The pharmacodynamics describes either concentration effect relationship or the time course of pharmacological effect after dosing. Drug interaction. Drug-drug interaction, that is DDI, are defined as two or more drugs interacting in such a manner that the effectiveness or toxicity of one or more drugs is altered. Some result in preventable medication errors associated with serious adverse events and death. Alternately, some DDIs can be used to our advantage. Pharmacogenic factors operate at the pharmacokinetic and the pharmacodynamic levels. Polymorphisms in drug metabolizing enzymes, transporters, and or pharmacological targets of drugs may profoundly influence the dose-response relationship between the individuals. Current practice of anesthesia rarely takes into account the inter-individual variations, and standard dosing is often applied. As more information becomes available, it is likely that presenting pharmacogenetic variables before elective cases will increase the patient safely due to a decrease in the number of adverse drug reactions. Pediatric pharmacology. Infants and children differ markedly from adult patients because their metabolism is often immature and their principal physiological functions are different. Volumes of distribution, that is blood, extravascular, etc., flows, cardiac output, CSF turnover, etc., and barriers are different from those of adult patients. For example, many cytochrome P415 isoform are not mature until the age of 1 year, and some children are deficient until the age of 4 years. Due to the difficulty of studying clinical pharmacology in the pediatric population, research in this area lags behind than in adults. This leads us to principles defined in adult bodies when deciding on the dosing regimens, which may not apply to the very young. Now, what is the summary of basic pharmacology? Now, I come to summary. This is drug administration. It may be intravascular, extra, or regional. Drug absorption. Unchanged drug moves from the site of administration to the site of measurement within the body. Drug distribution. Reversible transfer of drug to and from the site of measurement. Transport across membrane. Non-ionized form is more lipid soluble and crosses membranes more easily. Drug elimination, excretion of metabolism, bindings to plasma proteins, unbound moieties diffuse across the biological membranes more easily. Pharmacokinetics, that is what the body does to the drug. What the body does to the drug, this is pharmacokinetics. And what is pharmacodynamics? What the drug does to the body. Drug-drug interaction. When two or more drugs interact to decrease the effectiveness or cause the toxicity of one or more of the drugs. Thank you. This comes to the end of my lecture. I hope everybody will appreciate this, and if some points are missing, I'll try to come up next time to you with all these points. Thank you. We'll see shortly for other chapters.